So this outbreak occurred in a small town in Indiana. This is Scott County, Indiana. And there were a lot of things that contributed to this. This is a rural area. There is a lack of education. A lot of the people are, when I say lack of education, I mean there's a lack of HIV or healthcare education. There's also a high percentage of people who haven't graduated high school. A poor area. Lots of people don't have access to good health care. So lack of adequate health care is a big problem for a lot of places in rural America. And they kind of started so shortly after an opioid drug problem started, and then people switched from the drug Opana. They switched to heroin. And why do people do drugs? Well, there's lots of reasons people do drugs, but the rate of drug use really increases when you lack resources, when you lack education, and people were sharing needles. In fact, people were sometimes sharing needles over 300 times until the needles broke off during use. Because in Scott County, Indiana, needle exchange was not possible. In fact, buying syringes, if you didn't have a medical need for them, like diabetes, was criminal. And so that led to not people saying, I can't buy needles. Well, I guess, darn, I can't shoot drugs now. That leads to people sharing needles. So they had a big spike in hepatitis C, and they had a big spike in HIV. And this is a pretty rural town, so there's not that many people there. They had on average 5 cases reported a year. They went from 5 cases to 215. During this time period. In fact, for a while there, Scott County, Indiana had a higher incidence of HIV than any place in sub-Saharan Africa. And again, a lot of things contributed to this. There was one clinic, it was a Planned Parenthood clinic that was offering testing, and then, Planned Parenthood. So they that got shut down. So then there was nobody testing people, and eventually they had to admit they had an epidemic here, and they changed some policies. They improved they improved testing. They initially started off with a needle exchange program, but you had to register with your initials and your birthday, and so that was a lot of people didn't want to do that. They eventually got this under control, and I encourage all of you guys to read through this case study and think about things, what could have been done earlier to help mitigate this. One thing, and I know I've mentioned this before, and I'll mention this again, but regulating people's behavior by making things illegal doesn't really work. We tried this at the great experiment with Prohibition, and Prohibition did not reduce alcohol consumption, but it did create the mafia. So, there's that. There have been a lot of studies that people, are really concerned that, if we do things like have needle exchange programs, and if we give out free condoms, and if we put programs in place to mitigate the risk of HIV transmission, then people will just start having more sex and using more IV drugs. And they found that's not the case. People who don't want to inject heroin are not going to suddenly start injecting heroin just because you can get free needles. People who don't want to have lots of sex, people who don't visit orgies, are not going to suddenly start visiting orgies because they can find free condoms. Anyway, we'll move on from here. Or I'll just keep talking forever, which I'm sure you don't really want to listen to. Okay. How do we prevent transmission of HIV? Well, fortunately, the HIV particle is actually really, really fragile. It's enveloped. And because the virus is enveloped, with a very fragile envelope, soap works wonders, just like with coronavirus. Soap is really effective. It's also susceptible to drying out, and other disinfectants, Lysol, for example, are also really effective at destroying HIV. And I can't believe I have to say this, but based on one of the more recent press conferences from our fearless leader, you cannot drink or use any disinfectant like Lysol or bleach internally to kill HIV or coronavirus, because that will also damage your cells too. Okay. Oh, yes, I want to emphasize this. This is important. All right. Contact with sweat, saliva, or tears has never been shown to result in transmission. Handshaking and hugging has also not ever been associated with transmission. So this is really important to note. And I know things have improved a lot in the United States from the 80s, when people were treating folks with HIV like lepers and treating gay folks like lepers, which, note, leprosy is not super common anymore, but you shouldn't treat lepers like lepers either. They're people and deserve respect. But anyway, things have gotten a lot better in the States since the 80s, but I do want to emphasize this. You do not need to be afraid of people because they're gay or have HIV. This is also important. So in order for a virus or a bacteria to survive in a vector, it has to be evolved or adapted to survive and or replicate in the tick or the mosquito or whatever, and HIV can't do that. So HIV cannot be transmitted by mosquitoes, right? So only through intimate contact or sharing of blood or other bodily fluids like semen. Okay. So how do we prevent the spread of HIV? You can tell people to practice abstinence, and people who want to practice abstinence will do that. People who don't want to practice abstinence will not do that. There have been, again, a lot of studies that have shown abstinence-only education leads to an increase in teen pregnancy. Abstinence-only education results in an increase in sexually transmitted infections. Abstinence-only education is worse than no education at all. But a proper health sex ed class is really effective at reducing the spread of HIV, other sexually transmitted infections, and proper sex ed is also good at reducing unwanted pregnancies. Use of barrier methods like condoms is very, very effective, and there's some myths out there that condoms aren't that effective, and so then people don't use them. Just use a condom. Like, do whatever you want to do. I don't care what you do. Just use a condom when you do it. It is important to note, though, that you need to wear a condom from the beginning, and I say this because people have asked me before, do you only need to use a condom, towards the end? No, you need to use a condom before penetration starts. And again, that relates to the fact that friction causes tiny little tears in the skin. And these tears can be nearly microscopic. This does not have to be particularly rough sex, but tiny little tears in the skin allow blood to move back and forth. So before penetration, put on a condom. This is an interesting innovation, particularly for women, intravaginal virucides or microbiocides. So you use this as a gel, kind of squeeze it. I don't know. There's a tube. You squeeze the tube. You can put some tenofovir gel used before intercourse, and this kills viruses. So this is pretty effective, especially for women. Pre-exposure prophylaxis. This is very, very effective. If you are that's a V, not a C. If you are in a group that is particularly at risk for contracting HIV, so if you're a man who has sex with men, or if you are a woman with multiple sexual partners, or if you are a sex worker, being on PrEP is a very, very good thing. So PrEP is taking antiviral retrotherapy, or sometimes this acronym is still used, highly active antiretroviral therapy. Taking this before you get HIV, and so you have a high dose of these antiretroviral drugs in your body before you have sex, and this is very effective at preventing the transmission of HIV. There has been debate, though, well, if you give people PrEP, they're just going to have more risky sex. As I was on my soapbox a little earlier, no, that's not true. People who didn't want to have gay orgies before are not going to have gay orgies now, or we don't need to limit it. People who wanted to have bisexual orgies before are not going to have bisexual orgies now just because PrEP is available. And there's also data to back me up on this. And I've uploaded actually a paper on Canvas where they have done epidemiological assays, and they've given people access to PrEP for free as part of the study, and they've monitored these people over time, and using PrEP did not drastically change the incidence of other sexually transmitted infections or HIV, and in some cases, people's risky behavior actually went down after they were on PrEP. So no, giving people PrEP is not going to turn them into sexual maniacs. There have been some really good success stories where cities have actually started giving out PrEP for free to at-risk populations, and they found this is actually very cost-effective. It's much more cost-effective for the city to provide PrEP than it is to actually provide care to those people after they get infected. Prevention is always cheaper than trying to cure someone later. Post-exposure prophylaxis. So the effectiveness of this varies based on the exposure and when you start it. Post-exposure prophylaxis is not as effective as PrEP, but this is, let's say that a person had a needle stick injury, or a person was raped, and they're afraid that they might have been exposed to HIV or other pathogens. You can be put on post-exposure prophylaxis. This is relatively effective if you start it right away. If you don't do this right away, then it's less effective. But this is still definitely better than nothing. And if you have the needle stick injury and you report it right away and you start your post-exposure prophylaxis on the same day, odds are pretty good it'll be effective. If you wait a day or two or three, then less effective. But still definitely better than nothing. And so some communities have started giving out PrEP. Some communities have needle exchange programs, which has been really, really effective. Other communities have free condoms available. And so if you're in New York, there's an app, and you can use the app to tell you, you enter in your current address, and it will tell you the closest place to find a free condom. And these sorts of programs have been pretty successful in reducing the transmission of not just HIV, but other sexually transmitted infections. And again, if you're not the type of person who needs to find free condoms, this app did nothing to change your life. If you did not know this app existed before, then you're not going to become a very promiscuous person just because this program is available. Okay, I'll get off my soapbox now. Back on to HIV and its progression. So, what happens after you're exposed to HIV? Well, if you acquire HIV, if your immune system doesn't fight it off, and you become infected, there's this eclipse period. So I should start off saying, on the x-axis, we've got time, days. The y-axis, we've got our course of infection. And this eclipse period is a period of time where the number of viruses in your system is not high enough to detect, and your body is also not producing antibodies to the virus yet. So if you get tested during this period of time, then they can't pick it up. So if you get tested right after you've been exposed, you'll get a false negative. Now, right after you get infected, there's an acute phase within the first 2 to 4 weeks. And you might have a mild flu-like symptoms. This is acute retroviral syndrome. Let's see, acute retroviral syndrome. Not everybody gets this. It's mild flu-like. You maybe get a headache, you get a fever, but it's pretty mild. It's probably not severe enough for you to actually go to the doctor. Not everybody gets this. And then you go into a clinical latency. And I should emphasize here, this is a clinical latency where you don't have clinical symptoms, but it's not a true latency. Your body is still fighting off the infection and losing. The virus is slowly destroying your immune system, and then you're progressively getting worse. And then after a period of time, years, like 10 or 12 years, then you progress to AIDS. All right, so initially, the virus is going to start replicating. The virus infects immune cells at the site of infection. So these would be like, say, macrophages in the genital region. So the virus, will say in a woman, is going to infect macrophages or T cells in the vagina and the cervix. And then those immune cells are going to travel to the gut. They're going to travel to the gut-associated lymphoid tissue. They're going to travel to the gut, and they're going to start replicating more. So the virus is essentially using this macrophage like a taxi and taking it to an area where there's a lot more immune cells where it can start replicating. Now, at this point, PCR, or nucleic acid amplification test, would be able to pick up the virus. The longer you are on the course of infection, the easier it is to detect. But 10, 12 days, let's see, this actually says for about 15 days that you can, this is, nucleic acid test. So the scale here, we'll say 12 days. You could pick this up on a good test, looking for the genome. And then your body starts to notice the infection. Your body starts producing antibodies. And then you could pick those up about 2 weeks. We'll say 15 days. Now, I want to I want to make a point here and emphasize, your body does produce antibodies to HIV. They just don't work. They're not effective at neutralizing the virus, but you do have an immune response to it. All right, so if we're talking about early in infection, so there's a big spike initially in the number of viruses, and you have an immune response. And then everything kind of plateaus for a little bit. And after that, the virus is spreading. It's infecting your lymph cells throughout your body, and it's infecting after initial infection be macrophages, later in infection CD4 positive T cells, and it just keeps going, slowly destroying your T cells until your immune system is demolished, and then you start getting secondary infections. And so that would be this kind of after the break, that would be here. Now, again, you are producing antibodies. They just don't work. And there's a lot of reasons for that. The virus evolves very, very quickly. Also, the virus doesn't present a lot of good targets for an antibody. Really, the only possible target is the envelope protein, the spike protein, and there's not a ton of envelope spikes on the virus to start off with, and then for the virus to be neutralized, you've got to prevent entry. And finding an antibody that can bind the spike and prevent it from either binding to the cell or triggering fusion is difficult. And then again, the virus evolves so quickly. If your immune system does produce an antibody that works, then those viruses stop, but there's thousands of other variations of a virus in your body, and they keep reproducing. Now, officially, AIDS is when the CD4 positive T cell count is below 200 cells per microliter. And they used to not actually provide you with antiretroviral therapy until you had AIDS. And so while you were still in clinical latency, you wouldn't get treatment, which is really, really short-sighted in my personal opinion. And they've made a lot of recommendations now to change this. And so they're now recommending that as soon as you have HIV detection, like on day one, like the test comes back positive for HIV, on day one, you should start therapy for a number of reasons. One, the outcomes are better. The less your immune system is destroyed, the better. Two, someone who is on ART, on antiviral retrotherapy, their counts of the virus are so low in their body that they can't transmit it to other people. So not only are you improving the outcome for the individual patient, but you're also preventing them from spreading it to other people. So they used to not start treatment until you've actually had full-blown AIDS. Now they recommend you start treatment as soon as you come back with an HIV positive test. Let's see. Okay. And as a reminder, you probably should go back to the immunology chapter and refresh yourself on all of the things that CD4 positive helper T cells do. But in short, your CD4 positive helper T cells help stimulate all the other cells in your immune system. So without these, your immune system is tragically crippled. But if you don't remember how CD4 T cells work, you should go back and revisit the immunology chapter. Now, there are very few people that are called elite suppressors or long-term non-progressors. So what does that mean? So normally, if we look at someone's course of infection, so we've got viral load and T cells on the y-axis, and we've got time on the x for both. So for most people, the virus, again, slowly peaks during the acute phase and then kind of plateaus, and then it goes back up again. And your immune response plummets, right? So this is for most people. But there's a few people who are elite suppressors or long-term non-progressors. And so they have an acute phase, and these very small percentage of people, their immune response is actually able to suppress the virus. And they have very, very low levels of circulating HIV. So these people, we study a lot. We take their blood, and there's been a lot of research to figure out how their immune system is able to do that. And they're able to produce broadly neutralizing antibodies. And this has really helped the efforts neutralizing. This has really helped the efforts in producing a vaccine, but a vaccine is still decades or more away. That there's a lot of challenges when it comes to producing a vaccine. But the goal is can we make a vaccine that generates broadly neutralizing antibodies in the general population like these people have? One of the problems with this is these folks, they won the genetic lottery, or that they were really lucky. And when your body produces antibodies, there is a process of fine-tuning, and the genes in your B cells have to get rearranged and produce an antibody that can bind to a lot of different strains of HIV and neutralize it. And so producing a vaccine with an antigen, like some version of that spike protein, that actually induces that B cell response, that humoral response. So your B cells will produce those broadly neutralizing antibodies, is a lot more difficult than we would like it to be. But there's a lot of effort, like hundreds of millions of dollars worth of research and effort in trying to do just that. And there have been a few clinical trials. The best clinical trials so far produced a protection rate of about 33%, which, is not phenomenal. It's not something that's going to be rolled out widespread, but 33% protection is, better than zero. Sometimes the flu vaccine, the seasonal flu vaccine, year to year, the protection rate's about 50%. So the best we've done with HIV so far is 33%. That's not 0.33%. That's 33%. And we're hoping to improve upon that. And the goal is to be able to get your body to produce these broadly neutralizing antibodies after immunization. Okay, so how is HIV diagnosed? So it's an ELISA on a stick. They look for your immune response. They look for the physical presence of the virus. They look at it a couple different ways. So they look for the antigen. And so there's an antibody on the piece of paper in the HIV test. And there's and if the antibody in the test binds to the antigen, then it shows up a different color. They also look for antibodies. So they put the antigen in the paper, and then if your body's producing antibodies, then it will bind to the antigen in the paper, and you'll get a color change. So this is just like a pregnancy test or rapid strep test. It's an ELISA on a stick, on a piece of paper. So they look both ways. It's both an indirect and a direct ELISA. If these words like ELISA and indirect and direct ELISA are foreign to you, again, go back to the immunology chapter. Now, if you have a positive test based on this ELISA, then they'll go back and they'll do a nucleic acid test, and they'll try to count the number of viral genomes that you have. Now, they're making these tests more widely available, and you can go into any Planned Parenthood clinic. You can go to your doctor's office, and you can even mail order some of these HIV tests now. The CDC recommends that every person gets tested at least once. I know I've been tested when in prenatal care. You show up and you're like, I'm pregnant. And they say, let's verify that. And then they take your blood and they run a gazillion tests, and they make sure that you don't have HIV or other sexually transmitted infections and so forth. And they insisted on doing this for my second pregnancy too, when I'm like, hey, I've already had my blood drawn lots and lots and lots with my first pregnancy. Do we need to go through this again? And they're like, yes, we do. And I know I don't have HIV, just a couple years after being tested the first time, but they don't know that. And from a scientific point of view, they are correct. It's always better to test and know. Also, if you engage in sex with multiple partners or any other high-risk behavior, you should just get yourself tested every so many months, because if it's during that eclipse period, you'll get that false negative.